Hi there, everyone. Thank you for coming today. I'm sorry I can't be there with you. As you can see, I'm in clinics, it just wasn't going to work. I hope you've had a fantastic 2 or 3 days so far. I was up there last year and I was really desperate to get up this year, just to talk about what we do from a veterinary side, how we can interact and collaborate with like-minded people like yourselves. So you can see the screen there. The talk today is a focus on BLS and ALS in the canine patient. I'll talk a bit about who we are for those who didn't come to the talk last year, and then we'll do a very quick run through some of the key pieces that we're looking at. Obviously, I can't see who's in the room. For those of you who want to talk to me afterwards, my details are along the bottom, and obviously you can access me via the WEM team if needed. But feel free to use my number or my email address or get in touch via Facebook or LinkedIn. So pre-veterinary care, canine BLS and ALS in a nutshell. So the scope of today's talk, run through a little bit of what we did last year. We're going to look at an initiative called Recover, and then we're going to touch on basic life support. CPR is the major aspect there. We'll look at airway access. We'll look at advanced life support, what that means for the canine patient, monitoring, vascular access, drugs, defibrillators, and then how we can push the boundaries by working in collaboration with our medical friends. It's a lot to get in. So this is us. It's my wife and I. We have a business called Veterinary Task Force. We deliver veterinary assurance and bespoke solutions for working animals and associated professionals. So the bread and butter is the working dog community, and we offer a veterinary assurance package where we can really tie up that well-being and welfare for the working dogs. Our sort of baseline offering is an accredited first aid package for working dog handlers. So we have moulage on that, and that's something that's not really offered in the veterinary world. And it's an interactive scenario-based course. We also have first aid kits and look to collaborate where we can. And one of our sort of, things is coming up to the WEM conference for the last couple of years. Last year, we talked about managing your canine patient. So that was assessing the patient, looking at the legal side, which we'll touch on briefly this afternoon, looking at the March principles or ABC and some of the main casualty scenarios that you might find, a lot of which obviously tie in with BLS and ALS. And then if you're stuck in a place for a prolonged period of time, it might be overseas or up in the hills, how to look after your canine patient for a protracted period of time. So the Recover initiative, broken down, is the reassessment campaign on veterinary resuscitation. Started in 2010, and it was a team of ECC specialists in the vet world internationally who got together, and they had 3 goals. And their 3 goals were to develop some guidelines using evidence base, and they pulled together over 1,000 pieces of scientific evidence of the varying levels of quality from a scientific point of view, and they brought them together and created an exhaustive review of all of the CPR literature in the veterinary world, obviously cross-referenced to the medical world as well. Education, so they, as an organisation, as a non-profit, provide the only standardised CPR training to veterinary professionals. So us as vets, vet nurses and allied veterinary professionals across the world should be really using the Recover guidelines as our standard. And a lot of other first aid providers will use this as well. They're freely accessible. The training, obviously, you have to buy into. And this is what we train our dog handlers in when we're out on the road. And the third thing is research. So informing and supporting. They've done that literature review. They're now looking at prospective studies. Who's it for? Veterinary professionals, but also on their website, they now have first responders and working animal handlers, which is amazing. So we're already doing the working animal bit in the UK. The first responder bit I'll talk about later. And then there's the bit for pet owners and pet professionals. They cover 5 domains: preparedness and prevention, BLS, ALS monitoring, and post-cardiac arrest care. And the website is there. But if people want to get in touch, I can direct them. Success rates. This is interesting. So, and some of you in the room may be experts in this and know the up-to-date stats from a human point of view. But when we compare human outcomes to canine and feline patients, there is a lower chance of survival to discharge. So this is obviously in the hospital setting rather than out in the field for cats and dogs versus humans. Humans, and this is from one of those papers, and it may be even better now, but 45% will achieve return of spontaneous circulation following CPR, with an estimated discharge rate of 20 to 25. Now, that is obviously caveated with whatever context the paper was done in. So I've just put those up there as headline figures. But from an animal point of view, the discharge rate is 6 to 19% after they've obviously had, hopefully, a return to spontaneous circulation. So when I'm out on the road, I'm teaching 6% versus 25%. And one of the rationales for developing this Recover guideline, or the Recover initiative, and really pushing it, is to improve that 6%. We need to get that up. So if we can train the dog handlers, if we can train the medics who are responding or working with these animals in really efficient CPR, then we can improve that. And also, because these are professional organisations, we can get the data and feed that into their studies. There was due to be updated guidance in 2019. So the guidance, I said 2010, they actually pushed out the first lot of guidance in 2012. So 10 years old. Obviously it still stands, but they've got more evidence they can put in. It's a vast, vast piece of work. Basic life support. So you know this already, but the way we look at it is it's an immediate response. We need to think about airway management, rapid recognition of CPA. We don't want to be wasting any time here. And we need to start CPR as soon as possible. And I'll show you some algorithms a bit later, which will talk you through that. Chest compressions, well, they're critical as they are in humans. But as you know, technique is as important as doing them. So ineffective chest compressions are just delaying everything else. And basically, when you're doing your gaps in between, I know this is really obvious, but your little check of the rhythm, if you've got an ECG hooked up, or your pulse check, if you haven't got monitoring equipment, needs to be swift and effective. And obviously checking for breathing and things. So you're going back to that CPR cycle. Provision of ventilation as well. Obviously, if you can intubate, and we'll talk about that, then you can carry on providing that ventilation, getting rid of that CO2 while still doing your chest compressions. The other option, obviously, is doing mouth to snout. The majority of canine and feline cardiac arrests are due to non-cardiac root causes, and so if you can get ventilation in early, then that is going to help. What you don't want to be doing is wasting time not doing chest compressions in order to try and achieve that ventilation. So I'm going to go back to a slide we had last year just to do a quick refresher on how we look at the primary survey with working dogs. So you've got your mnemonics there. You've got ABC, CAB, March. You'll all be aware of the debate between ABC and CAB in the human world, and actually there's no direct evidence comparing the efficacy of CAB versus ABC resuscitation techniques in veterinary patients. And I've talked before about that. We just need to get that the compressions going, get that pump action working. Don't delay the chest compressions. The operational environment will dictate, obviously, which you're going to use. We use the March principles in our training because these are operational dogs. They might not be tactical, but they are potentially exposing themselves to higher threat environments. And so therefore, we do need to consider the M, which is massive hemorrhage. And as I say to them, once you're practicing this, you're doing this within seconds. You can see if there's massive hemorrhage prior to your airway assessment or breathing interventions. So you've got massive hemorrhage, airway, respiration, circulation, head injury, hypothermia. And those of you who may have seen some of the American military training modules, this is where this is derived from, moved across to American military working dogs and then across to the UK. But it's about that environment and situation that dictates what order you do things in. Here's one of the algorithms. They've got 3. Keep it nice and simple, that boils out of this huge piece of work. So if you focus on the right-hand side of the page, we'll talk about the bottom half of that left image later, but you have an unresponsive apneic patient, you need to initiate CPR immediately. And I will go into more detail about how we do it, and you can see this image again later. So CPR, chest compressions. Position, where you're going to have it. The dog needs to be on its side. There's one caveat to that. And you need to have the spine up against your knees. Unfortunately, because I can't be there, I can't demonstrate to you. But in effect, doing CPR with a dog that's not symmetrical, if you're at the leg side of the dog, potentially you're going to be pushing that dog away from you as you do CPR. So have its back against your legs, and it's going to stay nice and close to your legs. Positioning of your hands, so it's the point of elbow when pulled back. Now on a normal dog, beauty's in the eye of the beholder, but Labrador Spaniel, so a non-giant breed, non-sight hound, non-French Bulldog, so your normal working dog as you would perceive it, you would almost just do it on the highest point of their chest. If it's a greyhound or a smaller animal, that heart's going to be sitting a bit lower down in their chest. Obviously, tiny animals, you may end up actually not doing proper chest compressions, but using a hand, where's my camera, doing a pump action like that. And you may get that in certain circumstances. You're going to go a third to half of the depth, and the rate 100 to 120 per minute. Don't stop for the first 2 minutes. You're using the thoracic pump theory. Obviously, you're going to get some compression on the heart, but you're compressing the thorax to then aid the pumping of the heart. You need to prime that pump, as you know, so the first 2 minutes is critical. Full recoil, so push hard, push fast, and you can do interposed abdominal compressions if you have enough people, and you can alternate the chest compressions with the abdominal ones. A couple of pictures here. Ventilation. So 8 to 10 breaths per minute if intubated, so 1 every 6 seconds. If you may have an ambu bag connected, and you continue your compressions throughout. If it's mouth to snout, then you are making a seal over the dog's mouth, close its mouth, and you're breathing through the nostrils. But you need to stop your chest compressions, because otherwise that air is going to go nowhere. It's just going to circulate around the oropharynx. So if you want to make sure you're going to have decent ventilation with that 30 to 2 ratio, you need to have it in those gaps. So we do a 30 to 2. There's a picture there. If it's a single rescuer, if you're on your own, chest compressions, do 2 minutes, and then you can start that cycle of 30 to 2. Intubation. So if you are going to do this, and I'll talk about the legal aspects at the end. Think about your equipment. What tube sizes? Are you going to take some with you? Are you going to have separate kit? So in our dogs, the sizes we use range from 4 for a really small dog, right up to 11 sometimes. And obviously, some dogs need the tubes cut down to size. You want it to be going to the thoracic inlet, so you can sort of judge it size-wise that way. Some people use the nostrils to look at and work out whether that's going to be a sensible size to go down. You need to use a laryngoscope if you haven't done it before, but certainly if you're doing chest compressions, the dog's on its side, using a Larry is going to help you do it whilst that dog's moving. Now, we use a Larry slightly differently to you. So we will normally have the dog facing us, so you're eye to eye with the dog, and the nurse will hold the dog's head. You will then lower the dog's lower jaw, its mandible, pull the tongue out carefully, and then use the Larry to guide it over the tongue. So you're pushing the tongue down, which is what the Larry's for, but you're doing it from the other angle rather than, so you're doing it face to face, same orientation rather than over the top. Think about a lubricant, and then think about a syringe or a manometer to get that pressure right on the cuff, and then tie it in position. You've got some nice big canine teeth, so you can normally tie it over the top of the muzzle. A couple of pictures here. So you'll recognise this. I haven't got a laser pointer, but in effect, you've got the epiglottis. You're going to go over the top of that. If they are a short-faced breed or brachycephalic, you may have an excessively large soft palate that you need to move out of the way. And then you will go in between the arytenoid cartilages over the top. Just a quick sidebar, if you're doing cats, they get laryngeal spasm. So you need to think about lidocaine and spraying that in. Other airway access, fun slide this one. So tracheotomy or tracheostomy, whatever your favoured term is. So if we're doing surgery on a French Bulldog, we always have a trach set ready in case their airway is compromised post-surgery. Normally they're in surgery because I'm improving their airways, but that's another story altogether. But in recovery, that's a critical time. So you can place trach tubes. There's recent talk of cricothyrotomies, and I think some of the referral centres with the ECC specialists are starting to do this a bit more. This is a very recent paper where they looked at some of the commercial cricothyrotomy kits. I don't know which ones you guys use, but there's a couple of pictures here, and that was a really good paper. And there's a video of how to do one of them a bit later, and I've got a link to it. So we probably haven't got time to run through it, but you can basically type in the name and find it, have a look at that paper. So emergency cricothyrotomy in dogs is what you need to look up, and it's free access. Decompression, always useful in a diagnostic scenario. We need to be promoting and getting our nurses to do thoracocentesis diagnostically at the point of admission to the clinics, but obviously decompression. That red line there is the 13th rib, which is the back rib of a dog. We normally insert a tube, or when we're doing thoracocentesis, between the 6th and 8th ribs. Obviously, same principle, going off the front of the rib rather than the back, and the risk of damage is far less than the risk of not doing anything. So if we have dyspneic patients, I'm doing a T-fast, and I'm also doing some chest taps as well. So we need to think about how we're going to roll this out into the field. Here's the cricothyrotomy again. This is a basic one without a kit. So it's a needle, there's a bougie to then slide an ET tube over the top. This is meant to be done, or possible to be done, conscious, because obviously most of our patients won't stay still for you. But I've not done this one conscious, but I think thinking about basic sedations is sensible as well. There's the YouTube link, but I would go to that paper because we haven't got time to link on that now. So I'll just show you again. So emergency cricothyrotomy in dogs. And people can contact me afterwards as well. Fine, so we've got about 15 minutes left. So we're going to talk about advanced life support. So the recover recommendations, don't worry too much about this slide because this goes into quite a bit of detail, but these were their key recommendations following their literature review. So it's talking about epinephrine doses. So that's the lower dose, and I've got a drugs chart later. Thinking about defib and when to do it. So it's warranted in animals with observed progression to pulseless VT or VF. Lots of people asked me about this up at WEM last year. So, and in that last year, we've been doing more sort of investigation into it as a company, but also it's out there more and more people are talking about it in the veterinary profession. You need to be doing your initial cycle of CPR if you're not sure what's gone on. So obviously if we had an anaesthetic emergency and we'd had the ECG on and we'd seen that pattern, well then we could think about defib straight away. Now, not all clinics have a defib, but you may do out in the field, or depending on what your circumstances are. So that's a bit of a disconnect there. So we need to think about how we can push out some guidance for this, because if you're giving defib, it's probably because it's a life or death situation. Open chest CPR might be considered in select cases. Now, I have done this once, but it was an anaesthetic one. So I was already there in surgery, and the dog did come back, and then sadly, it passed away later on. It didn't recover from its anaesthetic, but that is there as an option. That's not anything I'm going to go into in detail today, but it's something that is getting more and more talked about in the vet world. And then you need to think about drugs, particularly if it's in clinic. We need to think about reversals. Fine, my clicker is not currently working. Here it is. So I'm going to push this, the algorithm back up again. So if you look at the bottom right, you've got the green rectangle. So we've got initiate monitoring, obtain vascular access, and administer reversals. So monitoring, what do we need to do? We need to, if possible, think about end-tidal CO2. We do it with every single one of our anaesthetics. Not all clinics do, but it's becoming more and more the norm. But we can use it, as you know, in monitoring CPR to evaluate efficiency of chest compressions. So if we're hitting about 15 mils of mercury, great. And obviously, if there's some spontaneous circulation, we may, and it starts to breathe for itself, we may see a rapid increase. Now, the end-tidal CO2, we can look at that throughout the CPR cycle. Obviously, at the very beginning, it won't be very accurate, particularly if the animal's been asphyxiating or breath holding. But once we're sort of into a routine, it can be a useful tool. The one thing, as you know, that is not very reliable when we're doing CPR is ECG. So we need to be getting those leads connected, and we need to be thinking about that gap in between CPR cycles, so we can rapidly look at the trace and diagnose the rhythm. When we're attaching leads, we have a sort of basic 3-lead one. So quick picture there. So dog's normally on its back, or we roll it onto its back, and then it's going to be on its side, isn't it, for the CPR. Hairy beasts, these ones. Sometimes their armpits and groin are not that hairy. You need to be getting a good bit of skin. Electrode gel works wonders, but you're not going to be able to like shave and put little stickers on. You need to just be putting the crocodile clips on. This is a CPR situation, so it's going to pinch them. Well, if it stimulates them, that's great. But think about electrode gel just to form that seal. As I say, they might be a bit hairy. So you've got your yellow on your left, red on the right, easy to remember, and then back to left, you've got green. Okay, just bear with me, my clicker, which is separate system, it's just frozen. Okay, vascular access. So we've got a few ports of entry. And this is obviously critical for ongoing care, but we might need to give some emergency drugs. So if you've got enough people, you need to be thinking about getting IV access. So the main points, cephalic, and I've got a picture for that. That's the front leg. Saphenous is the back leg, jugular, and then the marginal ear vein. These guys have got massive ears generally. I've actually done one this morning. It was a dog that was sedated, Bernese mountain dog, 70 plus kilos, so same weight as me. And its cardiovascular system had sort of shut down a bit with its alpha-2 that we'd given it. And it was quite overweight. So we couldn't get the cephalic. So I could have gone saphenous, back leg, but it's got a problem with its back leg. That's why it's in. So we went for the marginal ear vein. And I'll show you a picture in a sec. So you can quite easily, with most dogs, grasp around the elbow, and that also helps stop them pulling back. Raise the vein by putting your thumb over the top. They've done a big old clip on this picture here, but normally you see the cephalic vein will run across from medially and then up over the top and up the front of the forearm or the antebrachium. On the back leg, you've got the saphenous, so you can either grasp the leg or just even put your thumb in at the top bit, so the most proximal part of where that vein is. So you can see that there. And if you're not sure which angle that runs at, it's running parallel with the foot. If you see that, you've got the foot that's grey, it's grey on my screen, and then you've got the vein that runs parallel. Thinking about intraosseous, so The only times I really need to do this are in paediatrics, so we get small kittens coming in, so we can then look at, I normally go into the femur for that. Femur and humerus are better than the tibia and ilium, but they are also options, particularly in the larger dogs. Picture here just to show you some of the sites. That's showing you, you're more than welcome to take photos of this. You've got your 4 points for access for intraosseous, and then you've got your veins as well. Jugular, obviously we use that for central lines, and we're not averse to doing cut downs if needed in an emergency situation. And then intratracheal. So we're getting the vascular access so we can give drugs if needed during CPR, but also if we want to give stuff in the post-op realm, fluids, etc. But from an emergency point of view, if we can't get vascular access, let's give something down the trachea. So you can use a feeding tube or a urinary catheter, and if you're intubated, obviously you can just detach your ambu bag or your oxygen flow and put the feeding tube down there. Normally you're giving about 10 times the dose for adrenaline, for example. Back to the algorithm, we're doing the bottom half now. So we've got 5-10 minutes, so we'll cover this off quite nicely. So this is where we're evaluating and we're thinking about the ECG trace. And what are we going to do? Are we giving drugs or are we doing defibs? So drugs and defibrillators. So if we've got pulseless electrical activity or asystole, then vasopressors and potentially anticholinergic drugs, atropine, etc., can be given. You want to be doing them every other cycle of CPR. You might go adrenaline, then atropine, and alternate. And if you go back to the previous slide, you can see it's got some suggestions there, but we do have a chart for drug doses. Patients in VF or pulseless VT should be electrically defibbed if available, or a precordial thump. So that is the thump on the chest. And I think, to be honest, if you were in an environment where nothing was going right, and even if you didn't have an ECG, you may give this a go. You've been doing chest compressions, so you may have damaged ribs already. I think it's worth just having that in your back pocket. Immediately after defib, you want to be doing another 2-minute cycle of basic life support. Get your chest compressions going rather than stacking up your defib options. And that's come from some of the recommendations. Emergency drug doses, we have these sort of ready on the wall. We don't always draw them up preemptively. It depends what level of risk we're at in terms of our anaesthetics, and obviously each patient's graded. AEDs, so it's thought that about 30% of all arrests are VF. Biphasic is preferred over monophasic, so it depends what you've got. Are you pulling something off the wall, or if you've got a huge paddle mounted, ready to go? There's some doses here, and actually there's a really good video online. It's really long, so I haven't sort of done it, but I've got a screenshot of it where they get a pointer dog and they just attach the connectors, the paddles on either side, just from a normal wall-mounted human AED. You need to be placing them on opposite sides of the thorax, over the costochondral junction, directly over the heart. So most fit, healthy breeds, you're gonna know where the heart is. You're not going to be able to feel it because that's the reason why you're doing this. But point of the elbow, where the elbow meets the chest, is the sort of the right area. But if you think about the size of the pads, they're going to probably be covering part of where the heart is, and the heart does take up quite a lot of a high percentage of the thoracic volume anyway. Paste or gel, great. Ideally, because shaving is going to take a long time. Unless you've got clippers and you've got a short-haired breed, then you won't be getting the bick out. If you have electric clippers, then you might be able to do that. So this guy here, this is a Facebook video. So if you type into Facebook, recover Q&A, it's at the top there. So automated defibrillators in dogs. It's really good. They talk through all the sort of pros and cons of stuff. So quick touch on legislation. What can we do? You do. And what do I want you to be able to do? Which is the more important question. So in the UK, we're working under the sort of two main laws. So the Animal Welfare Act, which what falls out of that is the Code of Practice for the Welfare of Dogs. So that's basically, look after your dog if you're caring for it. And that could indirectly apply to you out in the field as a keeper, or sort of at least somebody with knowledge who is, notionally looking after the dog. And it comes down to the 5 freedoms, making sure they're eating and drinking and they're comfortable and non-painful and able to do their normal behaviours. And you can do first aid under that. The Veterinary Surgeons Act is a bit different. So that's what I can do and what I can delegate to people, which includes medics, medical professionals, and dental practitioners. I should have said medical practitioners, that's the official term. And I've got more on that on the next slide. And then the Royal College Code of Professional Conduct. So that tells me what I can do without a slap on the wrist. But it falls out of the Veterinary Surgeons Act. Now, there's a paper in the States which looks at bringing together 18 key themes, key scenarios which dogs might be sort of put in from a trauma point of view, and how to deal with it as a handler with no training, as a first responder with no specific training, or as a first responder with additional canine training. But basically, there is no civilian EMS system to care for veterinary patients. In the States, it's a bit better. They can do a bit more. And in the UK, there's light at the end of the tunnel. So this was the paper I was talking about, best practice recommendations for pre-hospital veterinary care in dogs and cats. I talked a lot about that last year. And then there's the organisation BARTA, British Animal Rescue Trauma Association. So they are the people who help with horsebox RTCs, cows stuck in the mud. They're a fire service centric organisation, but we are on a canine working group looking at how we can train first responders to rescue that dog from that car, rescue that dog from that burning building. So there will be training coming out, and we're obviously doing training as well, working with other agencies. So what can you do? I'm not going to bore you with these. You're lucky because we haven't got enough time to cover it. But some really key take-homes from those 3 sort of substantial documents and legislative acts that we need to think about. But in summary, I've summarised it for you. Medical and dental practitioners, so technically that's doctors and dentists, although we know that probably should be widened, can treat, test and operate on dogs at the request of me as a member of the Royal College of Veterinary Surgeons. So that's brilliant. Let's get the training done, and then let's have some sort of feedback, telemedicine. I train a doctor or dentist, or we open up that definition of practitioner, and then we have some telemedicine reach back. Can I do it? Yes, you can. We have the audit trail. You've done the training. I'm happy you can do it. So that's IVs, that's intubation. Other medical staff can technically work under the Veterinary Surgeons Act Schedule 3, which is the exceptions. Now, the exceptions you may be able to see on the screen, but basically that talks about what nurses can do, but also what people can do to save life. Emergency first aid to save life, which you can see right in the middle of that screen in bold, just to the top right of that oval. Now, to me, if a dog needs CPR and it needs to be intubated, well, that's emergency first aid to save life. So we need the green light for this, and then we can train everybody, all of you in the room, to be able to do this. Let's just train you anyway, and then we'll get the green light. But we do need to think about other things like host nation legislation as well, because that might change things slightly. But that's not insurmountable. So to tie in the theme of the conference, pushing boundaries, what are we going to do? Hopefully I've given you a really nice flavour of what we can do, and probably you're just nodding your head going, yeah, we do that. You know how to do that. You're experts at doing that. You just need the confidence to be able to do it to a canine patient. And we've touched on the legislation. Well, let's start pushing the boundaries there. Let's start using that legislative act and working through, not under the radar, but going, right, well, let's train people, which we are going to be doing. that's already in the pipeline, and then people are prepared. And actually, what's the worst that's going to happen? The dog was dying. The statistics say 6% success rate for CPR. So to save its life, we need to do these things. Legal jurisdiction, I've touched on that. So if you're working for a client, if they got an agreement, if they looked at what's going to happen in their country, they might have it all sewn up if you're sort of joining something that's already established. But we can obviously help with that. Training courses for medics. So we are in talks with various organisations. So hopefully 2023 is going to be the year where we can look to get some of this training out on the road and sort of really pad out what I've touched on in this whistle stop tour. And we'll also be looking at the barter thing, so first responders, UK based that is. We're also looking at an expeditionary course for vets alongside WEM potentially, but ultimately sort of there may be access for medics on that. But it's really exciting. I think this is an area that we need to be doing, not just from a public perception, but these working dogs are unbelievable assets, and we need to be doing everything we can in our power. And as I say to people that I'm training, if you've done the training and you've done your best, that's all you can do. They get very bonded to the dogs because they are not just expensive, incredible assets for whatever deployment they're on, but they're obviously their friends as well. And even if you're sort of external, you're a medic who might be working alongside, you won't be able to miss that bond. And I think, if there's anything we can do to help that, then, let's do it. So there isn't a question and answer session, unfortunately. And some of you may have already left to go and watch the football. But if people want to get in touch with me, find me, either WhatsApp me on my number there or call me, or contact me via LinkedIn. I'm happy to talk through all things canine. Thank you very much.